Hello, 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 everyone. Welcome to another episode of Sree's Global COVID-19 Show. My name is Sree Sreenivasan, and it's my honor to convene this conversation around various aspects of the COVID-19 crisis. We have, over the last year, talked about everything from the pandemic to the health aspects, the financial aspects, and of course, the reckoning around racial justice. And we are today as the anniversary and the 1 year mark has passed. We've been looking and following, as the whole country has, the trial about the killing of George Floyd. And today we are able to bring some of these several strands together in an important conversation with Dr. Ayana Jordan, who is an addiction psychiatrist at the Yale School of Medicine, who's done research on racism as medical justification for police violence. We're also joined by Max Jordan Nguemeni Tiako, who is a student at the Yale School of Medicine and the host of Flip the Script podcast and columnist who writes a column called White Coat and a Hoodie. And he is a mentee of Dr. Jordan, and we'll be talking to both of them about various important topics during the crisis and what's happening. We'll talk about Derek Chauvin's trial and how George Floyd's drug use has been depicted, including issues related to addiction and racial disparities in treatment access. And we'll be talking about a special article that Dr. Jordan and other doctors have written about George Floyd's case and the use of the term excited delirium. So please stay tuned and please share this with your friends and family who can watch this around the world. Even if they can't watch this live, they can watch this right after. Hi, everyone. I'm Sree. Thank you so much for being here. I'm the Marshall Loeb Visiting Professor of Digital Innovation at the Stony Brook School of Journalism and the co-founder of Digimentors, a social, digital, and media events consulting business. We are so grateful that you are here with us today. Our show has been on the air for more than a year. We've had more than 450 guests from 75 cities and 20 plus countries. We had the chief scientist of the World Health Organization, and we're able to do this all because of our support from our fabulous producers, Rose Horowitz at Rose Horowitz 31 and Vandana Menon, Vandana_Menon. Please follow them on Twitter. And we are grateful to be on the channels of Scroll Global and Scroll.in. If you haven't seen our shows before, we'd love to hear from you. Tell us where you're watching from. Ask your questions. We'll be able to address them here. You can ask our guests anything. We'll want to tell you quickly about Digimentors. We are doing conferences, summits, webinars, talk shows, virtual events, and also hybrid events. So if you'd like to talk to us about your event, please get in touch. And we also want to tell you about my flagship event this year. Is Social Media Weekend is on May 21st and 22nd. Everything you want to know about digital and social media. It's online Friday night and Saturday on May 21st and 22nd. You can find tickets at smwknd.com, including early bird tickets. So please check out smwknd.com. And with that, I'm going to bring our guests on. Please share right now, tag a friend they can watch live or watch later. We're so grateful to have our fabulous guests here with us. So let me say hi and bring on Dr. Jordan and Max Jordan. Let's bring them on. Hello, everybody.
Hello, Sree. It's so great to be here. And I am just really excited that you are using your global platform to cover such an amazingly interesting and important topic. So it's really good to be with you this evening where I'm from in New Haven, Connecticut.
Thank you very much, Doc. Really happy to have you here. And let's say hi to Max. How are you?
Thank you so much for having me. I'm doing well. Also, zooming in from New Haven, Connecticut. As it turns out, Dr. Jordan is one of my mentors here at the medical school, and we hail from tough rivalries. I'm a Howard University alum, and she is from the other HU, Hampton University. So it's really. But I'm gonna let you have it because you're my senior. But yes. it is a delight to be in conversation with her on your platform. So thank you for having us.
Well, we're just delighted to have you here. We're going to have some fun, but this is a very serious topic about how addiction is treated in this country. So we'll be talking about that, but we'll take your questions to our two guests from the Yale School of Medicine. First, I want to ask Dr. Jordan, how are you doing? How has your family handled the pandemic? And we'll ask the same question of Max.
Yeah, thanks so much for that, Sree. I think before, and I would humbly ask, I know this is your show, but before we get started into really talking about how I'm doing, I just want to send my intense thoughts, love, and true prayers. It has been a time, and we are trying to deal with, of course, the trial that is happening right now. Because of the murder of George Floyd, but at the same time, realizing that, a young man, Daunte Wright, was assassinated just yesterday, 20 miles away from where George Floyd was killed. And Daunte Wright was a Black male, just 20 years old, that died by the hands of police. So I just want to bring his life and realize that, this is a major issue that we're constantly facing. And just when we're trying to wrestle with the reality of the trial of one Black man who was killed just a year ago, here we are in the same time frame, in the same proximity, right? Dealing with another Black man who was killed. So I just wanted to bring that into the space. I am doing, as well as I possibly can as a person of color, as a Black woman in this country, doing the type of research that I do. It's been really, really hard. I'm grateful to God that my family is fully vaccinated and we are alive. My father was diagnosed with COVID, but he pulled through. So I am grateful not to be one of the statistics in terms of the overwhelming disparity of COVID compared to white population. So for that, I am truly grateful. But I sincerely wish that there can be a time where I can just rest and not have to deal with the pain of yet another person that looks like me being gunned down in the street. And I'll tell you, Sree, I haven't had that luxury, and it's very painful. So here we are. And like I said, I'm really happy to come on your platform to raise awareness.
Well, thank you for that. And we're truly grateful that you're here. And I hope your family continues to be all right, especially after the vaccinations. I did want to say about the shooting that happened yesterday. The excuse that we heard today is that the officer was reaching for her taser and mistook her gun for her taser and shot him. We never hear of an officer reaching for a gun and shooting the taser by accident, and it's just so unacceptable. And on the heels of the incident in Virginia, where a military officer in fatigues was pepper sprayed and was lucky in a way that it wasn't even worse than that. Just tells you how, when we hear these cases of police misconduct, how terrible that is. Max, let's go to you. How are you handling everything? How's your family?
Thanks for asking. I mean, so my family is kind of all over, and similarly to Dr. Jordan, I've had quite a few family members who have had COVID. I'm originally from Cameroon. My mom had COVID like last year in May, and we're trying to figure out whether other family members, as I speak, have COVID. Cameroon is among other low and middle income countries where testing is not so readily accessible. So even if people are showing symptoms, it's not necessarily all that easy to get a test. So that, at the beginning of the pandemic, that was one of my huge concerns. Is my family going to be okay? Just knowing what the healthcare infrastructure is like in Cameroon generally. But as it turned out, well, at least as far as the data, that was reported showed, maybe the spread wasn't that bad, or maybe it just wasn't well reported because we have issues in terms of access to testing. My family in DC is mostly fine. Both my aunt and uncle, who are like my parents here in the United States, have been vaccinated. They're in their 60s, so I'm very grateful that both of them are vaccinated. And when I go home, I won't be concerned. I mean, I've been vaccinated too because I'm in medical school, but I won't be concerned about potentially, bringing the virus home or whatever, or that they might get sick from, I don't know, going to the grocery store. So most of the people around me who are elderly, like here in the US, have been vaccinated. I'm very glad. But there are, still younger family members who have not. And so I still have, carry a little bit of concern for my younger family members who have not yet been vaccinated, but otherwise, as a medical student, like I mostly, especially in my fourth year, I spend most of my time at home or going into the hospital, depending on whether I'm scheduled for a rotation. So I am shielded from a lot of, even the risk, right? I don't carry the same occupational risk as I don't know, internal medicine residents or people who work in the hospital in any given role, where, they are at greater risk for being exposed. So I'm very grateful, right, from that perspective. And similarly, I mean, I was gutted. So we're April 12th or something, right? It was just around this time last year that we were starting to find out about, Ahmaud Arbery in Georgia, and then George Floyd in May. I mean, this stuff, right, of police violence. My friend and I were just texting about this earlier, right? This is something that you hear of these cases, right? Like every 3 to 6 months. And it's, for me, I started medical school in 2016, right? That's when Philando Castile, among many others, were killed. So it's really eerie, right? Like I'm at the tail end of medical school, and another Black man is being shot in Minneapolis. I mean, and I had been saying this, right? Like police killings have literally bookended many sort of like key periods of my medical education. And I will say again, right, similarly, as again, being a med student, I am at home a lot or in the hospital, and I'm in New Haven, Connecticut, where I barely drive. I walk or bike, right? And so for many reasons, I am shielded from, including class, right? I'm shielded from the sort of excess exposure to police violence that many more Black folks around this country are, at risk of. A lot of this is very specifically, low income Black people who live in communities that are over policed, for sure. But also, in the South, it's still, you may still get pulled over on the highway, or if you live in a city where you have to drive a lot. So there's, that risk obviously still exists, and it's widespread. But I just want to acknowledge that, again, as a medical student at Yale, I am shielded from a lot of what is going on in the country, be it police, over policing, or COVID in these instances. So, yeah.
Well, thank you for sharing that. And the fact that you're not using your car as much gives you less exposure too, which is, so sad in a way that if you needed a car, that would add to your risk factors. We had Mitchell Silver, who is the commissioner of the Parks Commissioner in New York, who's a Black man, who said that he's always very careful when he goes out, because he doesn't know when he'll have to deal with the police. And this is the Parks Commissioner of New York City. So it tells you how pervasive the problems are. Let's just quickly look at some of the comments here. Jonathan's watching from the East Village. Jonathan's watched all 272 episodes. Neil's watching from Springfield, Virginia. Paula's watching from Tallahassee. Doug is watching from San Francisco. Everyone should subscribe to Doug's excellent COVID-related health communications newsletter. You can find it on Substack, douglevy.substack.com. And Apollo's watching from Montclair, New Jersey. Dr. Sujana Chandrasekhar says, it's like a deluge of awful stories of police violence. It's heartbreaking, she says. And Dr. Lippy Roy, who was my very first guest, says, no better guest than my wonderful friend and colleague, Dr. Ayana Jordan.
Love, love Libby.
Yeah.
Love her. Yeah.
Yeah, she's doing great. So let's, if we can, just get into the trial. I want to just hear from Dr. Jordan your kind of how it's going, and then could you talk about the aspects of the drug use and the allegations of it, and where that all fits into this?
Yeah. So, again, we were talking a little bit before we went live, Sree, and I think it's important to say here that I have made a conscious decision to not watch the coverage of the trial live to protect my own mental health and well-being, because the overwhelming connectedness to coverage just I knew would not be good for my own mental health and wellness. But what I do in order to really stay abreast of how the prosecution is doing is look at clips later online or on, via social media, and also through the newspaper, to just have an understanding of what's going on and being able to follow. I cannot believe I'm saying this, but I will say this. I am cautiously optimistic about how things are going right now. But I say that in context that it never ceases to amaze me how pervasive racism is in the carceral systems, especially in this country. So even though the testimony has been extremely impressive and also very convincing, and really just underscoring the facts of how George Floyd was murdered. It had nothing to do with his substance use or, alleged substance use disorder, but it was really through the actions of Derek Chauvin. I remain, like I said, cautiously optimistic that there will be some accountability on behalf of George Floyd and his family. So we'll see. But that's what I think. I think that we're doing well. In terms of really getting to the meat of the issue here is just within a long line of racialization in terms of seeing Black people, especially as less than the majority race, and in this country, that being white people. And I think it's important, because we're on a global platform, for me to just say that sometimes I use the word minoritized, because I know globally Black and other people of color are indeed the majority, but in this country, in the United States, we are made to feel less than, minoritized. And even in places in Florida or California where there is a majority minority, they are still really oppressed through structural racism. And I think that's really important, because that is integrated into the trial in terms of pervasiveness of whiteness, and how it has really been used through the lens of substance use as just a scapegoat to demean the humanity of George Floyd, as if you having a substance use disorder or having substances in his system could account for the behavior of the police officer who murdered him. And again, I was very heartened to hear both testimony from the pulmonologist and cardiologist to state that even with the levels of drugs present in the system, and if there were more that had nothing to do with the cause of death, and really the cause of death being as a result of lack of oxygen. So as an addiction psychiatrist and addiction doc, I am extremely offended but not surprised at how substance use is being weaponized. It's a systematic tool to discredit the humanity of someone that was killed. And like I said, this really has been tactics that have been ingrained in the history of the United States, really starting quite openly with the war on drugs in the late 60s, going into the 70s. And I always think it is really important for people to understand in this country how Nixon, really was very clear that the war on drugs really wasn't about drugs at all, right? As we continue to see the rate of drug overdoses increase despite all of these policies that were put in place to control drug use and drug supply. But like his top aide, Ehrlichman, stated, that the war on drugs was really a war on the anti-war left, being the Vietnam War at the time, and Black people. And so they knew it was not legal to vilify, right? So they heavily criminalized, and they used the war on drugs as a way to do that. And so again, with this history, it's important. I don't want to bore our listeners, but I think that people have to understand that what's happening to the assassination of George Floyd's character and using fentanyl and other opioids as a reason for justifying his death is in line with how drug use was used in the past to justify the involvement of many Black and Latinx men behind bars instead of getting treatment for their opioid use. At that time was really heroin, and then also justifying the just maltreatment of Black people specifically who were using cocaine at the time and were met with severe crimes, over involvement in policing, and we're still seeing that legacy today. So it's just tragic, and we hoped that we would be in a different place, but yet here we are. I'm so glad that you brought up this article, and I promise I will not hold up space because I want Max to get in here. He's done excellent work, and I'm so proud of him. But I do want to lift up this article that we wrote in Stat News, along with first author Jen Brody, who is a physician in Boston, as well as Sarah Wakeman, who is an addiction doc in Boston. And we talk about the, again, racialization of medicine as a justification to somehow get Derek Chauvin off the hook for what he did. And in this case, really, that is the so-called diagnosis of excited delirium, which we know is not a diagnosis at all. And when I say we, the medical system, delirium, which indeed is a medical disorder, is in fact in the DSM, which is the textbook that psychiatrists and many other physicians use around the world to really underscore medical diagnosis, along with data and to support those diagnoses. So delirium is real. It is a defined medical state, and it is defined as an acute change in attention, awareness, and cognition caused by underlying medical conditions, substance, or exposure. But I think what's really important for the audience to know, and I hope I'm not losing people, is that delirium is not associated with sudden death. And so what we're seeing now, and again, what was heard on the videotape with George Floyd, is one of the officers saying, Thomas Lane, he was a federal officer at the scene, he said, "I'm worried about excited delirium or whatever." So again, police are trained to believe that excited delirium is indeed a diagnosis when it's not. It was first described by Dr. Wetley in 1985, and it first emerged in his article in the Journal of Forensic Science, where they said it was characterized by a change of strength, along with mental and physiologic hyperarousal due to an intoxicant. And at that time, it was cocaine, but people have used excited delirium as a means of justifying death in police custody. And we saw that with who's the young man? Oh, Elijah McClain, and then Manuel Ellis, who all had substances in their system, yes, which of course can cause a delirium for sure, but again, does not cause sudden death. And what's important to know about this so-called excited delirium is why is it that people die in police custody? That's one. And then secondly, why is there an overrepresentation of excited delirium, specifically when we're dealing with Black men? So we can't discount that a lot of what we're seeing is not medicine at all, but yet a justification of using medical terms or syndromes as a reason to exchange or to excuse behavior, right? For what we're seeing, and it just really upsets me because as medical providers, physicians, scientists, we know that there is no data to support this so-called syndrome of excited delirium. And so what we're asking is that medical organizations are very clear that they take a stand and say, we denounce this diagnosis of medical delirium, excited delirium, because what's happening is what we're seeing in this case and also cases before is this is actually used as a reason for excusing or having accountability for the police officers who are involved in the deaths of these young Black men, right? And one of the things we say is silence can often signal, medical organizations being implicit. So I do think it's important to say that the WHO, the World Health Organization, the American Psychiatric Association, and American Medical Association have not endorsed excited delirium. They definitely have not endorsed it as a medical diagnosis. But what we're calling to say is you need to take a stand, right? You need to denounce it, actively denounce it, especially at a time like this when we're seeing this come into play. And the last thing I'll say, Sree, and then I promise to stop talking, but I get so passionate about this so that people understand, is that in 2014, the FBI's Law Enforcement Bulletin actually describes excited delirium syndrome. And so police officers and law enforcement are actually being taught about excited delirium, that it really is a thing. And it's really damaging, right? And in the worst cases, people are not being treated and getting the necessary medical attention that they need. But in the worst case, it actually results in death. And that's very concerning. And we need to do something about it.
Thank you for explaining that so wonderfully for us. We saw that Dr. Lippy Roy said that you, at a big 2019 conference, you gave a stunning plenary talk on systems of oppression, the ecology of health disparities in addiction. And folks, you can follow Dr. Ayana at Dr. Ayana Jordan on Twitter. So now let's go to Max, who's at Max Jordan _N on Twitter. First, your thoughts on the trial and any of the aspects that Dr. Jordan mentioned.
Yeah, I mean, so similarly, I have not been watching this trial. I mean, I am aware of what's being discussed and how it's being discussed just by virtue of, passive consumption on social media. But I also, I graduated college when George Zimmerman was on trial for the murder of Trayvon Martin, and I watched every single day of that trial, and I made the active decision to not do that this time around. But I keep seeing how the defense is using George Floyd's substance use as a justification or as evidence that he must have died of fentanyl use. First of all, as a medical student, that is not how one dies of any of overdose from an opioid, right? He would not be speaking right in the middle of that instance when Officer Chauvin had his knee on his neck. I mean, I've witnessed overdoses before, right? I've responded to overdoses before, so it's just kind of bonkers to me, right? That the defense will take such a non-evidence-based approach because I mean, I live by evidence as a medical trainee. I mean, literally is impossible, right? Like if someone is actually overdosing on fentanyl or on any given opioid, they're not telling you I can't breathe, right? Dr. Jordan, you're the addiction psychiatrist. You can tell me, you can say if I'm right or wrong here. But when I have, the few times that I have, like responded to an overdose, like literally on the street in Philadelphia, right? The persons were unresponsive, like entirely, right? They weren't saying I can't breathe. They weren't calling for their mother like George Floyd did. So the defense is full of crap, right? That from from my vantage point. But as Dr. Jordan said, more importantly, I think this use of how substance use and especially heroin use, right, has been so heroin use, of course, was sort of racialized in the since the 1960s, and we continue to see that today. And I think because fentanyl similarly has been the sort of villain in the last few years. It's almost as if and fentanyl is a contaminant that you see in many substances, be it cocaine, even heroin, even pills, right? Like fentanyl is detectable in a lot of different pills that people are taking because fentanyl is that sort of quote unquote contaminant. It has been villainized in the same way that I think heroin was already, previously villainized as the bad opioid, right? If you think about how even healthcare providers, perceive people who use heroin versus people who use, non-prescribed but prescription, like, synthetic opioids, there's a difference, right? So there's a good study, for instance, that showed that when this is an audit study, right? Where like you and I could like call an office and say, hey, I'm a person who needs treatment for opioid use disorder. Will you give me an appointment, right? And so when people are or when the auditors are asked, well, what is your substance or whatever, right? They're less likely. This is specific to people to providers who specifically prescribe buprenorphine, which is one of the sort of more recent treatments for opioid use disorder, right? They're less likely to offer treatment to people whose substance of use is heroin as opposed to synthetic opioids. And again, that is part of that is that like I said, right in the 1960s and forward, heroin was racialized back then as the like that is what black brown people use, right? Even though in the more recent years, heroin actually was not right was not the substance most used among black people. And if Dr. Joe, right, cocaine is
it still is not. Cocaine
yeah, it
kills
still isn't.
people than kills more black people than opioids. But I don't want to cut you off, Max, but I think what's upsetting, and I will promise I'll let you continue, but I think what's most upsetting here though is that the use of substances at all are being mentioned by the defense. It has nothing to do with why he is dead. It's just a distraction. And if there's one thing that I think we can take away from what we're seeing is that racism, not race, is the reason why the defense can even use substances as a reason for defending the police officer that murdered George Floyd. If we were looking at a white woman or a white man, again, it would not even come into play. And we see that in terms of globally, just it's everywhere. But even this year, look what happened to the white people that had mass shootings and were taken into custody safely, right? there's never a problem. Like Sree, you started off the beginning. There's never a problem with mistaking their, their gun for a taser or whatever, and then somehow shooting them and them dying. There's never a problem. The young white man who killed the Asian women in the parlor, he had
a bad day.
He had a bad day. And the characterization was he was a good person, a good student. He just had a bad day. But here we are dealing with a man who literally was not shooting anyone or doing anything, right? And ends up dead, but yet we're bringing in the past of what he's doing, and it has nothing to do with it. Even if he was someone that had an opioid use disorder, so what, right? And I think what Max is getting at is that even the ways in which you think about having someone with an opioid use disorder is heavily racialized. When we had people in the 60s and 70s that were using heroin, what was the reaction? It was the war on drugs. It was the doubling down. It was the legislation of them being sent to prison and total families and communities being obliterated. And then we go into the mid-2000s where you have this white impact, right? Where we have opioids in the form of not heroin initially, although it changed to heroin later for white people, but it was a response of compassion and treatment. And only then did we see the United States really investing millions of dollars into understanding how we might access treatment. Like Max was stating, even the ways in which we stratify care for Black people versus white people who have an opioid use disorder, white people are much more likely to receive buprenorphine, which is a medication that works, but is given through primary care offices and outpatient clinics, where people of color, mostly Black and Latinx people in this country, are offered methadone, which is highly restrictive. You have to go to a clinic up to 6 times a day. It takes 2 years for you to get a month of your medicine to take home. 2 years before you can even qualify for taking your medicine home for a month. It's ridiculous. And then there's no respect of our humanity, even if we're trying to get treatment. So that's one thing. But then beyond, once we're already in the grave, George Floyd was murdered. Here, you're seeing that the diagnosis of opioid use disorder is again being vilified, like Max was saying, in terms of a scapegoat for why perhaps he could have been a threat, or perhaps how the officer might have been scared, right? And like Max so aptly said, it has nothing to do with it. If someone had an opioid overdose, you would not be able to speak. But that wasn't even the case. And even if there was an opioid overdose, would that somehow make it okay for you to have a knee on someone's neck? It doesn't make sense. So what is upsetting to me as an addiction doctor who studies the impact of racism on outcomes for people who are not white is that not only are we not treated well in life when we want to gain help for, let's say, an opioid use disorder, which is a whole facet of George Floyd's story that we haven't even touched. I encourage you all to read the Washington Post article where I'm quoted talking about these things. But even in death, Black people are still vilified as having done something wrong. And that is by far the most painful experience of racism, because there is no reprieve. There's no reprieve of how the pain, right? And then we deal with a country that not only literally puts their knees on our neck, but figuratively through racist policies and drug laws. So now we have a situation that if his substance use had nothing to do with it, which it didn't. Don't just take Dr. Jordan's word for it. Hello, we have had many expert physicians testify to that. But what's so tragic is that now we are using terms like excited delirium, which have no medical validity, right? To justify the death of this young man. And it's disheartening. But Max, go ahead.
So, something else that I wanted to share that's relevant, that's, related to the pandemic. And I think George Floyd probably, I think he said it, I may not be remembering correctly, but he had COVID, right? And something this was discussed last year. People say, well, look at this brother had COVID. COVID didn't kill him, but it took police to kill him, right? But it's something that really struck a chord, because a little bit after, when the studies started coming out, and even before the studies, right, the news reports that were showing that we were seeing a significant spike of overdose deaths, especially in the Black community, and that's been shown in Philadelphia, in St. Louis, across many different cities, right? So, and the policies around, making treatment accessible during the pandemic have also been kind of racialized, right? Perhaps not intentionally, but ultimately, the outcomes of these policies likely fell on racial lines, right? So, one of the things that has affected everyone during this pandemic is the social isolation. And for people who use drugs, that has made it much more dangerous in terms of, being able to make sure that their supply is safe, or being able to access treatment appropriately. And so the federal government, right, made sort of headway in terms of making treatment more easily accessible. So, for instance, right, they decided that it's okay to use telemedicine to make buprenorphine, which is, the already outpatient, the already accessed via outpatient medicine option, right? It was okay to now use telemedicine to initiate a patient who is newly diagnosed, who is just starting treatment via telemedicine. But for people who, by the way, like Dr. Jordan said, have had to go to a methadone clinic, 6 times a week to, get their supply and then take their medication under supervision, that was not the case, right? People still had to show up in person, at least for initiation. And, and again, right, we have this issue with federalism in this country where, like, SAMHSA, the federal, the Substance Abuse and Mental Health Services Administration, releases guidelines that then may be, taken up by states in different ways, right? States have too much freedom, in my opinion. So SAMHSA releases these guidelines for making treatment for substance use disorder accessible, but in ways that continue to overexpose those who are patients in methadone clinics versus buprenorphine clinics, right? Those people who have to go to a methadone clinic a certain number of times, they have to get on the bus. They have to get there, which increases their risk of exposure to COVID. And then when they get there, so there's no telemedicine option, right, for people who have to go to get their medication at a methadone clinic. And of course, they relaxed the rules in terms of being able to get a take their medication home. But there was still a requirement, at least at initiation, that people show up in person at the beginning, right? And maybe people were able to get 1 week, 2 weeks, however. Different states decided to implement this take-home rule. But again, right, even in the relaxing of rules around access to treatment, there were, the way the rules were put together, there was a disproportionate impact on people who were already, right, sort of getting the short end of the stick in this treatment system. And there was more recent good evidence that so people who use drugs were at increased risk of getting COVID and at increased mortality of COVID compared to people who don't use drugs. But then when you also look within that subset of people who use drugs, Black people who use drugs were at increased risk of COVID compared to white people who use drugs and compared to Black people who don't use drugs, right? Both risk of getting COVID and mortality risk. So there's a sort of like double jeopardy, right, of people who use drugs and who are also Black in terms of both risk of getting COVID and mortality risk that I think we really failed as a society to protect them, right? At the moment, they were the most vulnerable from either right overdose or getting and potentially dying of COVID. Yeah, so go ahead.
Yeah, no, I think, Max, that you bring up a good point, and I think it's highly relevant to what's happening right now with the trial. Because, let's just go with what the defense is saying, that, okay, because of George Floyd's fentanyl use, that somehow, caused the state, which could justify the behavior that Derek Chauvin used. Let's just go with that for a second. I think what Max is bringing into this space is really important, because we know that people who had COVID are at higher rates of respiratory distress, right? Or at least insults to the respiratory system because of COVID. So that's one. So that's already George Floyd. And then on top of that, they're talking so much about fentanyl, and we know that fentanyl can compromise someone's ability to take deep breaths. So if it was the case, even just going off of what they said, that makes it even more out of order or inappropriate for this police officer to use the means in which he did, because that was putting George Floyd at even greater risk. So it doesn't make sense either way. At any way that you cut it, it just doesn't make sense. And I know that the attorneys have to put their best foot forward and come up with some type of case here, but it is infuriating that no one has quite simply brought into the impact of race on what is happening during the trial. And I would love to see someone bring that into the consciousness, or bring that into the courtroom, in terms of how are we thinking about the influence of race and even more racism in terms of what has happened to George Floyd. And it almost seems to me that there is this elephant in the room that we're talking about right now, Sree, on your platform. So thank you so much. But that is not being discussed in the courtroom. And I'm not a lawyer, so I cannot speak about that in any expert manner, but it's really upsetting. It's really upsetting that even in death, George Floyd is being vilified. And we know that it would not happen in the same way, even if it was a white person who used substances. It's just infuriating. So let's see what happens, but here we are,
Thank you. Dr. Lippy Roy says Black patients are disproportionately undertreated for pain and substance use disorders. Structural racism in healthcare needs to be addressed head on. We are heading towards the end of our show, but we did want to go to some of the comments and questions here. Apollo says, can we mention DMX getting addicted to crack cocaine at 14 in 1994, the gutting of President Carter's Mental Health Act by President Reagan, and the 97 Congress, and the flooding of crack cocaine in the 80s, and the century-long lie about excited delirium as seen in Birth of a Nation, and why we divorce addiction from mental health, trauma, and the Black experience. So we covered some aspects of this, but obviously not all of that. Maybe we can have Max address any of these aspects here.
I was born in 93, a year before the 1994 thing. So I only know about some. I know a little bit about the history of DMX substance use, and may he rest in peace. I've been seeing a lot of videos of him just extending kindness to many people, many strangers, in so many different settings that that man was a precious, just a precious human being, and of course, many of us have danced, partied to his music. Um, you, Similarly to what Dr. Jordan said earlier about the government's response to substance use disorders or substance use generally in the Black community versus in the white communities, the crack cocaine epidemic is emblematic of just that, right? When Black people use cocaine, when Black people use crack. It was punished more, crack was, racialized, right, as the Black drug, and sort of pure powder cocaine, or however people want to call it, was the sort of white version, no pun intended.
The yuppies doing it on Wall Street, it was like part of their, like a party drug, was how it was portrayed on TV.
Right, and some of the rationale behind making crack a more making crack or crack possession, or crack possession a more punishable offense was, I guess, theoretically, that crack was more dangerous because it was more addictive than powder cocaine or something along those lines. Dr. Jordan, please chime in and correct me if I'm wrong. Right, that was the rationale on the face or on the surface, but I mean, we have to be real with ourselves and admit that right, some of making the sentence 3 times higher, under the argument that, it's a more dangerous substance than its powder or white counterpart. Obviously, I mean, even I think under the law, you can defend. You can say that if something has a huge disproportionate impact on a given ethnic or racial group, then it counts as discrimination, right? So that's one thing in terms of how crack cocaine use was so much worsely punished in our criminal justice system. And from my vantage point, as someone, I specifically study perinatal substance use disorder, when I look at how prenatal substance use has been treated, both by from Congress, when Congress signed, capped out the Child Abuse and Protection Treatment Act or something like that, right, where to this day, half of the states in this country use a punitive approach to prenatal substance use, and some of that is born out of the vilification of Black women in the 90s who smoked crack, or who consumed crack / cocaine, right? And more and more recently, we see states adopting a less punitive approach to prenatal substance use, such that, for instance, when a pregnant person comes into treatment and happens to have a substance use disorder, the goal is to connect them with services they need, like social work, access to treat, like medication, access to social services they might be lacking. Sometimes lacking housing is an issue. So again, that though has been more so with the more recent opioid overdose epidemic, right? Where even when now pregnant people are coming to labor to birth in a hospital, we try really hard to there are approaches like rooming in, where there was a time where if a woman had a history of substance use, the baby was snatched from her right at birth, right? And it was like, shaming, mothers were shamed by nurses in the NICU and whatnot, right? We're shifting the approach to prenatal substance use. And I think a lot of that has to do with the fact that opioids, right, shaped the more recent conversation. And I'm going to let Dr. Jordan say more about why addiction is.
I appreciate that. I'll try and be brief. I think I just want to get to what the viewer talked about. I think is really important in terms of the doubling down of Reagan in what I consider a racist drug policy. And so, yes, Nixon really started this war on drugs that really led to a disproportionate amount of Black and Latino men specifically behind bars as a result of drug possession, not even selling drugs. But I don't think we talk enough about how Reagan kind of doubled down with reinforcing the Anti-Drug Abuse Act of 1986. And that is what Max was talking about, really led to mandatory minimum sentences for people who had the version of crack cocaine versus powder cocaine. And so you only had to have 5 grams of crack to the equivalent of 500 grams of powder cocaine in order to get the same minimum sentence, which is absolutely ridiculous when we know, again, going back to pseudoscience, which we're seeing here with the excited delirium nonsense, is that powder cocaine versus crack cocaine is the exact same substance. And so why do we see higher sentencing with less crack cocaine versus a much higher amount of powder cocaine? And that was all because it was clear that the formulation, right, of cocaine that Black people were more likely to use was crack cocaine, right, as opposed to the powder cocaine. And again, and we're still contending with this legacy today of the overwhelming presence of Black and Latinx people behind bars who are not getting treatment. And I think it's important to see how this lives out, because we know if you have a history of incarceration, it's much harder to get housing. Some places you cannot vote, right? You cannot fully initiate citizenship in your state. So then it affects one's ability to even want to initiate recovery or maintain recovery. So the legacy of these policies are quite far-reaching. And so I love that the viewer really brought into existence how Reagan really doubled down. Thanks, Libby. I think that's so right. The new Jim Crow. I have all of my addiction fellows read that. It talks about how really the carceral system, especially related to the war on drugs, is just the new Jim Crow, right? The new way to police and oppress Black bodies. I will say something briefly about CAPTA, which is really important for what Max was saying in terms of birthing people, which stands for the Child Abuse Prevention and Treatment Act. So Max, I think that you presented that in such a positive manner in terms of how it's being used in a more friendly way because of the changing face of who we're seeing having addiction. Yes, predominantly white women who are, giving birth as a result of their opioid use, which this same compassion was not extended to Black women who were using cocaine. But we just published a paper, and I encourage you all to check it out in Health Affairs blog late last year. It was called When Reimagining Systems of Safety, Take a Closer Look at the Child Welfare System. I published that along with, again, addiction medicine doc Sarah Wakeman and drug law policy scholar Leo Beletsky, because we talk about, even with that, Max, that there is a disproportionate enforcement of Black birthing persons who are overrepresented in the DCF system, right? Yeah. So even if there are the same substances used from a white person to a Black person, who's more likely to be reported? The Black person. Who's more likely to have DCF involved in their surveillance? The Black person. So again,
situations and reunification, all of that disproportionately affects Black. Yeah, yep, I agree. That's very.
I guess this is where, when somebody says there's no systemic racism in this country, this is just one example of racism that is really systemic. Folks, we are almost out of time, but I did want to give each of our speakers a chance to talk a little bit about their work and research, and we're going to bring up your Twitter feeds. We also wanted to kind of hear how you're using, the social and digital platforms to get the word out on what you're doing. So let's go to Dr. Jordan first. Tell us how you decided to use Twitter and how you've been using it to get your work done and grow your audience.
Yeah.
Why is that important for doctors like you?
Yeah, I'll be brief because it's 10:03 and people need to go on. But basically, I really started out as in Twitter as a way to share my work and scholarship as an addiction medicine doc, really focused on bringing awareness to structural racism in the ways in which people who are minoritized receive treatment or do not. But it has really evolved over time, and I see it much more. Yes, I share my work, but also in terms of physician activism. So as you can see, with the most recent killing, I changed my profile picture to reflect the young man who was indeed, I say, murdered by the hands of the police, whether it was accidental or not, and then really drawing attention to what we can do in terms of police reform in order to bring about change. And then another thing that we're doing in terms of excited delirium that I'd like to bring attention to on the Twitter feed is just really the policy where we're asking the APA, American Psychiatric Association, the AMA, American Medical Association, and the American College of Emergency Physicians to publicly denounce excited delirium. And if you follow me, you can just see that petition, sign on, because we are planning to have meetings with the leadership of those medical organizations to demand that they denounce excited delirium. And if you can't find it on my Twitter feed, because I've been tweeting so much about what has happened with the trial or with the most recent killing of the young man, go to change.org and just type in excited delirium and we will come up. So I'm very grateful to work in an institution that supports this physician activism. But I think one of the things, Sree, that I love about your platform is that I cannot be silent when people are dying from preventable causes like racism. And so if I'm able to use my platform to bring about awareness and understanding, and then activism, that is great. So thank you so much, Sree. You are awesome. I will be tuning in. What a fantastic show.
Well, thank you. And I just want to say, I liked how you've also put in that you're fully vaccinated in your Twitter name so that people know. And that's a way of conveying, because as we know, in some, there is a lot of vaccine skepticism in this country. There's also vaccine hesitancy, even among people who believe the science. But because of the way folks of color have been treated in this country, they might be hesitant to take it. But you are affecting people just in your Twitter name. That's an example of how you did that, and you call yourself fully vaccinated. Let's get Max Jordan in and have him talk about we'll show his Twitter feed as well.
Thanks, Sree. You probably noticed that my Twitter feed is also probably full of retweets from the last few days. So yeah, I've had this account for a long time, from I think when I was in grad school a couple of years ago. I tweet mostly about whatever is going on in the news that I care about, some amount of research, and I have a podcast to promote when I'm actively publishing episodes. So a lot of my research is basically, as I mentioned earlier, about prenatal substance use and how we handle that as a healthcare system, and also more broadly speaking, substance use disorders and the quality of care for people who use drugs. I also do some research in some research related to medical education broadly. For the most part, I use Twitter to share research that I find interesting, outside of my own. So whenever I have a bunch of Google alerts for scholars whose work I follow closely. And so whenever they publish something new, or whenever something related to their work is published, or even my research interest comes up, if I read the paper, I'll share it, especially if it's related to health equity. I post my podcast. I follow a lot of people in sociology and other social sciences. So and a lot of Black journalists. So I use my account to also just sort of further amplify those words. And whenever I randomly write an article somewhere, I will obviously use my account to to further broadcast it. I've luckily before also used Twitter to reach out to editors, right? I had a post in a piece in the Washington Post that came from me literally asking, "Hey, editors, I would like to write about this issue. This is why, and this is why I'm the best person to write about it." And the editor reached out to me, and I had the piece published. So that's kind of
Max, I
my
want you
official
to
Twitter.
briefly just tell the viewers where you are going to be training. We are so proud of you. You're leaving us at Yale and going on to some other school up north. You want to tell them where you're going?
I'm going to Brigham and Women's in Boston. It's one of the Harvard affiliated internal medicine programs. I'm really excited. New Haven, it's a see you later. It's not a goodbye.
I just want to point out you write at maxjordanwrites.com, and you were named a Forbes under 30 star. We'll pretend your professor and mentor is not listening. Why are you make it part of your mission to write so much and publish and do the podcast? Medical doctors and medical students are so busy already. So we'll pretend that the doctor's not here, Max, so you can answer that and tell us why you've made this, talking about this, part of your mission. Also, one of your columns is about having a white coat and a hoodie. And you mentioned Trayvon Martin. You know, he lost his life in part because he was wearing a hoodie. And so I feel like this is all tied together.
Yeah, I write because it's really cathartic. And I write about things that upset me. So when I'm really upset, writing is one of the ways I sort of let that anger go, basically. And so, especially, I think I feel better suited to write more so about either personal experiences or things that I have some kind of expertise in. And then I use a podcast for the rest, right? I can't write about everything. I can't write about access to cancer drugs. I'm not fit to. I mean, it takes a lot of reading about the subject and reading around the subject. So I choose to write only about things that I feel I either have lived experience about or enough credibility and expertise in, and then use a podcast to really help amplify voices in the work of people who are focused on health equity. I think my main motivation in starting the podcast was that I felt, there's a gap in medical education that's pretty glaring in terms of how are we discussing health equity in our curricula. And podcasting it's nice bite-sized learning. I listen to podcasts while I'm doing the dishes or like walking to the gym. So that was basically the motivation. I can't write about every problem related to health equity. And so here comes the podcast, and I have historians and anthropologists and, public health folks. I had Dr. Jordan herself on the podcast. So that's my contribution without, taking the front stage, basically, right? Because again, I can't write about everything. So
and the podcast called Flip the Script. And so definitely look at that. I'm going to ask each of our guests a final thought. And I'll give them a minute just to think about their final thought. I want to tell you about some upcoming shows we have in our little orbit here. We have a show that's coming up. Our friend Stefan Kaplan is hosting the Spin It Social Hour on Thursday at 9 p.m. His guest is Roxanne Busher Overton from San Francisco, where photographers share their journeys. You'll definitely want to check that out. And then on Sunday, Neil Parekh is guest hosting the New York Times Read Along, where we read the New York Times out loud like crazy people at 8:30 a.m. Eastern. Neil is guest hosting for me. We'll be talking to Robert Strauss, who wrote a book called Worst President Ever. Not that one, surprisingly, and you'll learn why. And we will also be having, speaking of doctors, our show She's on Call, hosted by Dr. Sujana Chandrasekhar and Marina Korean, two surgeons. We'll be talking all about allergies this coming Sunday, 11 a.m. Eastern, on She's on Call on all the social media channels. So now let's get back to our two guests and ask them for some final thoughts, and then we'll let them go. So over to you. We'll start with Dr. Jordan.
Yeah, thank you so much, Sree. I was really sitting here contemplating. I'll be brief. I want justice for George Floyd, and I am really counting on medical organizations to do the right thing, denounce excited delirium once and for all. It is not a medical entity. We will not allow racist diagnoses to be used as justifications for the killing of innocent people. And so we'll follow along, but at the end of the day, we will indeed have justice for George Floyd. And I'm counting on all of us collectively to do the right thing, and underscore the activism needed to address structural racism head on, like my colleague and friend, Dr. Roy, aptly stated.
Thank you. And please follow at Dr. Ayana Jordan on Twitter. Now let's go to Max.
I mean, similarly, I want to echo Dr. Jordan's words about medical organizations and, you know, our response, or their, I guess our, because I'm joining the profession in 2 months, or our responsibility to society. I think, you know, a lot of the issues that we encounter in terms of health inequities are, you know, are ailments of society, not you know, not meeting people's needs. And so I really want us as a medical profession to leverage the power that we have, you know, through our professional organizations and through the you know, the role that hospitals play as employers, the role that medical schools play as employers, and vessels to upward mobility, to really think about how we can address you know, society towards better policies, right? I mean, ultimately, all of the issues that we're here discussing tonight, these are policy decisions. These are decisions that are made in boardrooms with policymakers and whatnot. And there's only so much that one can do at the level of healthcare provision, which is incredibly important. But I want us to use our power beyond healthcare provision.
That's terrific. Thank you so much. And please follow Max. He's at Max Jordan _N. Some people may ask, are, you know, the two Jordan names, are you folks related? No, you work together. Dr. Jordan is one of Max's mentors, but they also have a rivalry that comes from going to rival HBCUs. Dr. Jordan went to Hampton, and Max went to, as you can see behind him, at Howard University.
It's all love, but we still have this rivalry.
And let's not forget, HBCUs are you know, on the rise and in the news, thanks to the Vice President Kamala Harris being a fellow Bison, and just so much goodwill around HBCUs now. So thank you so much for your time, your insights, for educating all of us. We're super, super grateful. And if we can help you with anything, please get in touch with us. We'd love to amplify what you're doing.
Awesome.